Hello everyone and welcome to my channel and another video, another case in clinical pharmacy. I am Joe, and for those of you who are new to the channel, this channel is dedicated to teach clinical pharmacy, focusing on evidence-based practice, more of clinical reasoning and case-based learning. So if you're interested in learning clinical pharmacy, make sure to subscribe to the channel and hit the bell button so you don't miss any of our future videos. Our discussion for today is about community-acquired pneumonia, a very common and serious respiratory infection that requires careful management. This presentation will take a case-based approach to guide you through the key steps in caring for hospitalized pneumonia patients, something that maybe many of you don't do or don't get to do if you're practicing in a community setting. And I'll take you from initial antibiotic selection to deselection of therapy, or stepping down, or narrowing the spectrum of the antibiotic, and finally transitioning the patient to outpatient care. We will explore evidence-based strategies to optimize outcomes while minimizing the risks of antibiotic resistance and other complications, of course. And by the end of the presentation, you should have a framework for managing pneumonia patients in your own clinical practice. And as always, if you need more information, if you need more training, I always encourage you to sign up for my course, my clinical pharmacy course, on my website www.clinicalpharmacycourses.com. The course is offered 100% online, and it teaches all aspects of clinical pharmacy in the didactic part, and also you have a practical online residency program on the course. So if you're interested, you can always join the full course, and you will learn more and more about clinical pharmacy. So let's get started and dive into our first case for the day. So this patient is a 62-year-old male with a history of COPD, who presents with symptoms of pneumonia, including cough, fever, and shortness of breath. His initial workup shows an elevated white blood cell count, fever, and imaging findings consistent with right lower lobe pneumonia. However, he does not meet criteria for severe pneumonia or the need for ICU level of care. Based on these findings, the diagnosis is community-acquired pneumonia requiring inpatient management, but not severe enough to admit the patient to intensive care. The key assessment points highlight that the patient is hemodynamically stable and does not require vasopressors or mechanical ventilation at this time, and that's why we did not admit him to the ICU. We can just admit him to a medical ward instead. And of course, this sets the stage for discussing what comes next. So I just want you to familiarize yourself with the initial workup. So how do we choose between inpatient versus outpatient community-acquired pneumonia management? We have different aspects that we have to look at. So for outpatient community-acquired pneumonia, there's usually low severity. We can go with oral monotherapy or antibiotic therapy, and it's usually sufficient. The typical pathogens are likely pneumococcus, maybe some atypical bacteria, and a 5-day course is the standard treatment duration. However, when we look at the inpatient, non-ICU or non-intensive care pneumonia cases, those are usually moderate in severity, and they need IV combination therapy at first, maybe a broader pathogen coverage as well, and then later on, when they get better, we transition them to oral therapy if we have an oral option. On the other hand, an ICU level community acquired pneumonia is usually very severe, and a patient may be going into respiratory failure or is already in respiratory failure, and those will need broadest spectrum of antibiotic coverage at first, what we call empiric antibiotic, and then we have to culture them and get consider resistant organisms as well in our initial coverage, and they probably will require a longer course of antibiotic. This is just to differentiate, to help you differentiate between the three different patients that we see with community-acquired pneumonia requiring hospitalization. Now, the 2019 IDSA guidelines recommend a risk stratified approach to empiric antibiotic therapy for non ICU inpatients without the risk factors for resistant organisms. So, there are two standard regimen options. Option one is to use a respiratory fluoroquinolone monotherapy, such as levofloxacin or moxifloxacin at the usual doses for pneumonia. So bear in mind that moxifloxacin is the same 400 milligrams daily for most indications, but levofloxacin can come in 500 milligrams and 750 milligrams and sometimes 250 milligrams. So for pneumonia in a patient with normal kidney function, the dose is 750 milligrams once daily. And if the kidney function is altered, you would adjust that dose based on that. Option two is to use a beta-lactam plus a macrolide combination. And for beta-lactams, they prefer a third generation cephalosporin such as ceftriaxone, maybe 1 to 2 grams a day. And then for macrolides, I would go with azithromycin because it's easier. It's 500 milligrams once daily and it has less drug-drug interactions than clarithromycin. Both regimens cover typical bacteria as well as atypical pathogens like Legionella, Mycoplasma, and Chlamydophila. All of them should be covered by either one of these regimens. The guideline emphasize not routinely adding coverage for MRSA or Pseudomonas. I mean, these are nasty bugs that can come from the community, especially in the MRSA part. Pseudomonas is usually a hospital acquired bug or a bug that we see a lot in hospitals more than in the community, but it can still come from the community as well. But the guideline doesn't really recommend to start with an MRSA coverage or a Pseudomonas coverage for empiric coverage in patients that are not very severe. However, there are specific risk factors that you should look at, and they may warrant expanding coverage to include MRSA and Pseudomonas. For instance, when you look at MRSA risk factors, and for those of you who don't know what MRSA is, it's methicillin resistant Staphylococcus aureus. So for those ones, some of the risk factors could be prior MRSA infection or even colonization, a recent hospitalization with IV antibiotics, a cavitary infiltrate or empyema on X-ray, or maybe if you have a local MRSA prevalence of more than 20% in the area where the patient lived, that would be another risk factor. In these cases, you should probably consider adding an anti-MRSA antibiotic such as vancomycin or linezolid. For the Pseudomonas bug, the risk factors may include structural lung disease, any prior Pseudomonas isolation, frequent antibiotic exposure, and also recent hospitalization would be another risk factor. So if you have any of the risk factors for Pseudomonas, you should probably consider starting with or adding an anti-pseudomonal antibiotic, and examples on that would be something like piperacillin tazobactam, or maybe ceftazidime or cefepime instead of the ceftriaxone for the initial regimen. So back to our patient. He is a 62-year-old male with COPD, And we've assessed the risk factors for resistant organisms such as MRSA and Pseudomonas that we just talked about. They have no prior history of resistant organisms, no recent hospitalizations, no structural lung disease beyond their COPD, and no cavitary lesions on the imaging. So this suggests a lower risk of resistant pathogens, and based on this, we've selected a regimen of ceftriaxone 1 gram IV daily, in addition to azithromycin 500 milligrams IV daily to cover the atypical bugs. Now, this combination should be broad enough to cover Streptococcus pneumonia, Haemophilus influenza, and Moraxella catarrhalis, and other atypical organisms as well. The key is tailoring the empiric antibiotic choice to the patient's specific risk factors and clinical presentation, of course, rather than automatically using a broader antibiotic regimen. So now the patient is getting better, and we're thinking, or we should be thinking about switching them from IV antibiotics to oral antibiotics. But in order to do that, we have to assess multiple areas and multiple symptoms and as well as vital signs to make sure that the patient is suitable for that switch. So the key criteria for transitioning a patient from IV to oral antibiotics are clinical stability markers, and these include like hemodynamically stabilizing the patient, being afebrile for at least 24 to 48 hours, having a respiratory improvement, tolerating oral intake, because we're going to give him an oral antibiotic, so you need to make sure that the patient can swallow. And when I say that because I see a lot of patients that are unable to swallow due to other conditions. It might be an older patient that had a stroke and they have dysphagia. So if he's not going to be able to swallow the antibiotic, he's not going to take it, right? So you need to assess that as well. And you need to make sure that the patient has a normal mental status, because if the patient is demented, he's going to forget to take the antibiotic anyway. So he might not be the right candidate for switching to oral antibiotics. Now let's go through the criteria quickly. Hemodynamically stable means no need for vasopressors, heart rate is under 100, systolic blood pressure is over 90. So that tells me the patient is pretty much hemodynamically stable. Afebrile means the patient has had a temperature under 38 degrees centigrade for at least 24 hours without antipyretics. Of course, you need to make sure that we're not giving them acetaminophen or ibuprofen or something. We need to make sure that without antipyretics, he is afebrile. Respiratory improvement means the oxygen saturation is over 90% on room air or at baseline, and that the respiratory rate is under 24. The patient must be able, like I mentioned before, to take medications orally, and you can assess that by seeing if the patient is able to take food orally or not. And lastly, the patient should be alert, oriented, and not have any acute encephalopathy, for instance. Meeting all of these criteria together indicates that the patient is clinically stable and ready to transition from IV to oral antibiotics. Now let's take a look at discharge planning and the oral regimen selection, because this is something that you would assess as a clinical pharmacist as well, and you would be asked about as a clinical pharmacist. So patients basically who have met the stability criteria can transition from IV to oral antibiotic regimens with equivalent spectrum coverage. Now, when we look at our patient, we gave ceftriaxone plus azithromycin. Now, we don't have ceftriaxone as oral therapy, but we do have azithromycin as oral formulation. So what we would recommend as clinical pharmacists is switching from a beta-lactam to a broad spectrum beta-lactam to another broad spectrum beta-lactam. And in this case, maybe amoxicillin clavulanate would be a good option to switch from ceftriaxone. And then you would dose it based on the kidney function, of course, and patient's age and weight and all that stuff. And then add azithromycin or switch azithromycin to oral therapy to complete the azithromycin that you already started in hospital. Now remember that with azithromycin, we do have two different ways of dosing it. So you can dose it as 500 milligrams daily for 3 days, or 500 milligrams on day one, and followed by 250 milligrams from day 2 to day 4, or to day 5, I'm sorry, 2, 3, 4, 5, yeah, for 4 days. So if you had already done that in an IV formulation, and you give the 500 milligram dose, you can switch to the 250 milligram dose oral azithromycin from day 2. Or if you had already given 500 IV on day 1 and then 250 IV on day 2, you can continue on day 3 with a 250 milligram oral azithromycin. Now, what if you had given 500 milligrams of azithromycin on day 1 and then another 500 on day 2, and now we want to switch? You would give a 500 oral on day 3. It's that simple. The bioavailability is quite almost 100%, so you can switch from IV to oral at the same dose. Um, Patients can often be discharged the same day as soon as we switch to oral therapy if they are or if they were deemed suitable for discharge. That means the patient can mobilize, can eat and drink normally, and there are no barriers for discharge. He can take care of himself, or he has a caregiver that can take care of them and make sure they take the antibiotics and all that stuff. The patient should continue taking the oral therapy to complete the full course, and this is another job that you have to do on discharge to counsel the patient on the importance of compliance and completing the full course of antibiotics, of course. And one more thing I want to mention is if the patient had already started a respiratory fluoroquinolone, for example, like the one I mentioned at the beginning, levofloxacin or moxifloxacin, you can also switch them to a once daily oral levofloxacin or moxifloxacin, because those are available in oral formulations. Okay, so a little bit about the duration of therapy. What do you think? 5 days versus 7 days versus 14 days. So the current evidence supports shorter antibiotic courses for uncomplicated community-acquired pneumonia. The 2019, I think, guidelines recommend a minimum of 5 days of treatment for standard duration, and patients should be afebrile for 48 to 72 hours before discontinuing antibiotics. The typical ceiling for non-complicated cases is a 7 days duration. So that being said, the duration can be or could be extended to 7 to 10 days in some situations. Let's say a patient has a complication like empyema or an abscess in the lung, then extending antibiotics would be an option in those patients. Or maybe the patient has MRSA or Pseudomonas, like we talked about before. Now, these are multi-drug resistant organisms, and extending the antibiotic therapy to 7 or up to 10 days wouldn't be a bad idea. And another case that you may need to extend antibiotics is if the patient is a slow healer. That means uh, they showed very slow clinical response by day 5. They're still sick. They look sick, and they're sometimes febrile and not very stable yet. You can always extend antibiotic duration in those patients. So they are getting better, but they're getting better at a very slower rate. Of course, markers such as procalcitonin can help guide discontinuation of antibiotics in uncertain cases. So keep that in mind when you're ordering your laboratory markers every day. So procalcitonin specifically can tell you if the bacterial infection has cleared or not. A few key takeaways today for the managing of community-acquired pneumonia are to risk stratify before prescribing and to avoid overtreatment, to try to transition to oral antibiotics early enough, and to keep the duration of treatment as short as possible. Um, Risk stratifying using severity scores such as the CURB 65 or the PSI scoring system helps determine the appropriate site of care and the initial antibiotic regimen as well. Broad coverage for MRSA and Pseudomonas is not routinely needed, and you should probably reserve these for patients with documented risk factors. Try to switch from IV to oral antibiotics once the patient is clinically stable, as this is a safe, effective, and method to do, and enables timely hospital discharge as well, so that you don't keep the bed occupied when the patient is already stable. Other patients are waiting for that bed that are in more serious cases. And for most uncomplicated community-acquired pneumonia cases with appropriate clinical response, just a 5 to 7 day course of antibiotic should be sufficient. Now, this concludes our presentation for today. Let me know what you think in the comments, and if you have experienced patients with community-acquired pneumonia that ended up hospitalized, what did you choose for them? Do you follow any guidelines wherever you live? Um, and one more thing that like it's my out of curiosity actually, do you have a preference when it comes to macrolides, or is azithromycin available where you live? Would you go for azithromycin versus clarithromycin, and why? I'm really curious to know how other countries choose their macrolide. Is it based on availability, or is it based on other factors as well? Thank you all for checking in. And as a reminder, please, if you're not um, on the channel yet, make sure to subscribe to the channel and hit the bell button so that you get notified of future videos. And make sure to check out my website, www.clinicalpharmacycourses.com. I'm going to leave it in the description. We teach clinical pharmacy and other courses as well, 100% online and certificate-based course. So if you're interested in becoming a clinical pharmacist, this would be your first step. Check it out on our website, www.clinicalpharmacycourses.com. Thank you, and I'll see you in the next video.